It gets spicy in the comments section. So we are back to talk about the comments from the reaction slash debate that Dave Feldman and I did. And you guys, as always, had a lot to say. Here are my responses and some from Dave Feldman. If you are new here, please go watch the debate first. I am Dr. Lily Johnston. I'm a board certified vascular surgeon, but I specialize in cardiometabolic prevention. So hopefully you will never need me as a surgeon. At Dean Martin, 1071 says, if LDL drugs worked, there would be vast amounts of proof. The only people saying it does are the same people that sell that medicine. There are no studies by the American Cattlemen's Association. Why not? The studies are not really possible. There is no way to study all the reasons people have heart attacks. Sugar causes vein damage. That's been known forever, but vein damage isn't talked about in the heart attack discussion, but that's exactly what causes them. Explain that. We also have a comment from at Charles Patrick, 8650. If statins worked, coronary artery disease would be rare. Let's talk about it. There is plenty of evidence that giving lipid-lowering therapy, whether it's a statin or another agent, is beneficial, especially for secondary prevention. That means for patients who have known plaque and have already had a heart attack, a stroke, a limb event like scare for a limb loss, acute limb ischemia, something like that, where the circulation to the leg goes badly. There's pretty good evidence for that. Now, do people still have events despite that medication? Yes, they do. Does lipid lowering cure heart disease? It absolutely does not. And there is this tension between the fact that there is something called residual risk, meaning even though we lower your risk, there's risk left over that we have not treated with lipid lowering therapy or really any therapy, right? Aspirin by itself reduces risk, but not enough. Lipid lowering therapy by itself reduces risk, but not enough. This is why many of us are in the business of trying to understand the whole constellation of things that make up an individual's reason for having plaque and for having unstable plaque that might rupture and cause one of these devastating events. So is it the incontrovertible proof that Dave and his cohorts would have us believe? Absolutely not. And I still believe it's beneficial for a large swath of my patients who have this unstable plaque that has led them to have a real serious scare in their health. But that is perhaps a conversation for another day.
Dave is so humble and diplomatic to the point that he gives his detractors so much room, and yet they are closed-minded, snarky, and arrogant. He continually pfeffers on his podcast that Simon Hill is a good guy, but I just don't see it. From right at the beginning, Hill says he admires the individuals with personal stories and that he, quote, wants to believe them, close quote, suggesting he doesn't. Dave's humility and the true of his hypothesis will win out. Thank you for the comment. For what it's worth, I do actually think Simon does believe that a number of the stories that we're covering in the Cholesterol Code documentary are coming from a good place of people just trying to, work with their illnesses. And I think he believes a number of them. But yeah, that said, I really appreciate the comment.
At JPAT, simply cannot believe you gave this guy airtime. They faked their data and are now blaming the AI, unsubscribing. So I'm sorry to see you go, JP. You've been on this channel with us for a little while, and I am sorry that you don't feel like this is a place that is worth your time anymore. Here's my position on this. I have a lot of patients who come to me from the keto low carb space, and they say things like, there's a study that shows that there's no correlation between ApoB and plaque progression. I, as a physician, lose everybody's buy-in when I say, you're wrong, you don't know anything, that's crap. And I feel as though it's important to really understand what the literature and the data are saying and to talk with the people who are generating it so that I can understand, because I may still at the end of the day disagree, but I'd like to disagree on facts. So the fact is not that they fabricated or falsified their data. They didn't. They had it analyzed by a company that provided inaccurate or at least unreproducible or unverifiable results that disagree with 3 other independent analyses. Therefore, I am willing to continue a conversation. I am willing to learn more and to try to understand what the position is of my patients who believe this and how to navigate a very messy space where the data, in my opinion, at the population level are quite clear and the data for an individual are murky, and there is a lot of balance between risks and benefits in their mind that they want for me to understand, hear, and respond to. And I feel like the best way for me to respond is to take the deepest dive into all sides of this issue that I can. And we will never move the conversation forward if we cannot have a debate, a disagreement, a civilized conversation about the pros and cons of all of the evidence. That is how we bring our understanding to the next level. That is how we figure out who's right and where we have unanswered questions. So I'm sorry to see you go, and I hope that there are others who will appreciate the conversation and the need for this debate and the civil disagreement, the civil discourse that science is intended to foster.
As a scientist, I find Dave's communication style highly annoying. He throws out concepts and ideas without properly explaining any of the underlying reasoning, and even worse, he keeps hinting at other possible arguments for his stance, but rather than making clear about it, he cloaks it in vague references to potential future explanations and then leaves it at that. If he wants to play scientist, I think it would be useful if he adopts a communication style that is more in line with his role, or more in line with this role. You do not need to make anything exciting or fun. Just be very clear in your reasoning and spell things out fully. Almost all scientists at some point have to teach. Many of us aren't necessarily that keen on teaching. However, the great upside to having to teach, especially undergrads, is that you learn to communicate a lot better. I truly appreciate Dave's dedication to science and this particular topic and all the resources he puts into it, but he might consider focusing on developing his scientific communication style. It will only help his impact and will make the community take him more seriously. Well, thank you for the comment. For what it's worth, what would help me, per what you were just now talking about, is if there were more specific examples, like what is a great example that you think I was stating but then kind of leaving up in the air. For what it's worth, social media can be a bit of a stream of consciousness, so what I try to do is I try to link to existing lectures or papers that have already been published, which I also can say that I do in playing the role of a scientist.
Art on blades. Longer discussion, please. Well, guess what? Dave and I have decided that we probably should do a formal debate. And to that end, I am going to address at Alan Brown, who says, "What a waste of my time." It ended up being a fireside chat. A cross-examination should follow the evidence wherever it leads and shouldn't let a witness close a line of questioning with a plausible sounding deflection. Feldman is known for his pivoting and deflection, and Lilly allows it with ease. Basically, lots of high-yield technical jargon to not answer the question. Nature CT comparison was a good example. That's a decently strong challenge, but the moment he wheels out the Miami heart-matched cohort rebuttal, she lets it go. Basically, Feldman is the one deciding what counts as a proportionate depth of engagement and is allowed to dictate the depth. Worse still, Lilly was basically apologizing for the punch before she actually threw it, which means I instantly give permission to brush it aside without taking any heat. So I can see why Feldman agreed to do the interview, because it's going to look like a rigorous audit to low-carb zealots and anyone who doesn't truly understand the subject matter. But in all truth, it was a modern podcast illusion. Lilly throwing softballs, theater rather than examination. A totally pointless interview. Here's what I'll say about this too, because in the spirit of a longer debate, there are going to be some ground rules. This was a reaction, and it wasn't intended as a debate where both sides had equal preparation, and clearly that showed through, at least for some of you. So we will be doing an actual debate. The terms of that debate are actually still under negotiation. So if you have thoughts about how you would like to see this go down, please put them in the comments below, and we will think about it, talk about it, and try to be very transparent, very open about how this is going to go down, what the rules are going to be, and you can bet I will be better prepared and probably come out swinging.
Feldman should go into politics. He can clearly lie with a smile on his face. This is kind of like mean tweets.
At David Z 641, I can imagine the conversation Lily has with someone that smokes 2 packs of cigarettes a day. At a population level, this is harmful. It may not be harmful for you, so it is your decision. If you're going to have nicotine withdrawal symptoms by stopping smoking, you have to balance that against the chance that continuing to smoke causes lung cancer. I can't tell you that continuing to smoke will cause lung cancer for you and that stopping will prevent it. So the point, of course, is that I am not firm enough with my patients potentially about the lipid lowering issue, or maybe even smoking. Here is the truth. Somebody who's smoking 2 packs a day knows darn well that that's not good for them. They know perfectly well that that is a problem for their health, and usually if they're coming to see me, for their brain or their heart or their legs, whatever the case may be. I have not once had good success telling a patient that stopping smoking is a problem and having them be like, wow, thanks, doc. I never knew that. I'm so glad you said something. If I had only known, I just would have, wouldn't have kept smoking for so long. The other thing that does not work is shaming people or being a fearmonger and telling them that they have to do this or else something terrible will happen. And I've tried, believe me. I remember being in the emergency department and talking to a patient who had an acute limb ischemic event, meaning one of the blood vessels in his leg suddenly clotted off, and he was in a lot of pain and was at very high risk for losing the leg if we didn't do something. And I told him, I said, look, you can pick your cigarettes or you can pick your leg. And in that moment, I meant it, but it's also like not a very kind and compassionate thing to say. But I'm also not convinced that it makes any difference, right? I don't know whether he quit smoking or not, but it's a fine line for people who have these addictive, maladaptive behaviors. And the paternalistic fear-mongering doesn't go any better for lipid lowering than it does for smoking. So I can tell people all day long, sir, you have a CAC of 1500, you have severe plaque in your arteries, you are coming to see me because you don't feel well and there's a problem. My recommendation is that we manage all possible sources of your plaque formation. But I mean, if they ask me, what am I going to say? Can I promise you that taking this pill is going to prevent you from having a heart attack or stroke? I can't say that. It's not true. So yeah, I mean, you're right. I do have a conversation with people about risks and benefits because I think that that's called informed consent. And I feel strongly that that is a really important part of my job. There is no free lunch, whether it is a medication, whether it is no medication, and lifestyle intervention alone, there is always a set of risks and benefits associated with that. So I'm not going to apologize for not being a very paternalistic doctor who shakes my finger at patients and says, you must do this because I said so. I don't think that that builds trust. I don't think that builds a therapeutic relationship. And I think in 2026, when there is so much mistrust, and maybe deservedly so, of the medical industry, it does not serve anybody for me to stand up and just tell people that they're wrong, I'm right, and they need to do what I say. So maybe that's not the right approach, but it's what I take. And I think that that's what resonates most with me as a clinician. And I hope it's working for my patients.
Thanks, very useful discussion. I remain puzzled about why the pro-anti presentations pertaining to Feldman-Norwitz et al. Camp never seem to discuss the lipid triad outside of the lean mass hyperresponder context. My understanding is that the lean mass hyperresponder phenotype is thought to be uncommon, and hence there is presumably a much larger population of metabolically healthy people with very high LDL, high HDL, and low triglycerides. This is my situation and my motivation for following the lean mass hyperresponder ApoB cardiovascular disease risk debate. Has somebody looked at this broader group and how their cardiovascular disease risk relates to the general population and or the lean mass hyperresponder group? I understand that lean mass hyperresponder people have the dietary choice to control ApoB and are special in that regard. But it seems that the relevant issue is much broader than lean mass hyperresponders with potentially much larger sample sizes and funding opportunities. If the non-lean mass hyperresponder triad group is already well characterized in terms of cardiovascular disease risk, can you please post some references? I have failed to find any such studies. Many thanks. Thank you for the comment. And yes, actually, even before we started this study, I was interested in any studies that had this triad. And there were two that come to mind. One is from Jeppesen, and the other, I'm not sure who the author was, but it was looking at the Framingham offspring study. And in both those cases, it had those three markers subsetted out to where you could see high LDL alongside high HDL and low triglycerides, or at least at a modest degree. And for what it's worth, we are putting together the funding for the companion study to Keto CTA, which is called the Triad Study. And we're using, it's going to have a more permissive eligibility. I can't say for sure what it is, but I wouldn't be surprised if, for example, we're taking in folks who have an HDL of 50 or higher and triglycerides of 100 and lower, and possibly some other more permissive eligibility with regard to cardiovascular disease risk, so that it's much more generalizable.
At HVD, Hagen says, why is the ankle brachial index, or ABI, not mentioned? It's a simple non-invasive test that compares blood pressure in the ankle and arm to detect peripheral artery disease. It does not say everything about plaque on other places in the body, but as far as I understand, it's rare to have a good ABI while there is a lot of plaque in the heart. My ABI is 1.06, but the doctor said I should bring my LDL below 100 milligrams per deciliter. Why should I do that when my arteries are clean? So HVD, this is a good question. Ankle brachial index is actually a test I order a lot as a vascular surgeon because it speaks to the poor circulation in the legs, which is something that I treat. And the sad fact is that it is a late marker when it's a problem of vascular disease. Because it's detecting a change in pressure in the arteries have to be about 70 to 80% narrowed full of plaque before you'll see a change in pressure, especially at rest. There are people who will have a change in their ankle brachial index, or ABI, with exercise before we have it at rest alone. But if we're just checking at rest, then it's a very late marker for pretty severe disease. I don't want my arteries 80% full before I figure that out with an ABI. So it's very specific, however. If your ABI is abnormal, then yes, I think there's a problem, and there's probably a problem in many different places in the rest of the body. But an ABI of 1.06 does not mean there's no plaque. It doesn't mean that the arteries in your heart and your neck are clean necessarily, although it might. More dedicated imaging is needed for that. Unfortunately, ABI is just not a great screening test for early detection of plaque.
The man gave everything to do this experiment. Thank you for the comment. I can't say that I gave everything, but would it be a considerable amount for a decade now? That part is true.
At the proof with Simon Hill. Thanks, Simon, for chiming in. Lily's point about validation against IVUS in people with lots of plaque is a good one, something I've raised, which raises issues around validity in low plaque populations. Her point on non-calcified plaque volume, NCPV, being the plaque of interest is also good, and I agree. I believe in an abstract, if you say regression or progression and you are referring to non-calcified plaque volume, it should be clearly stated and not stated as regression, as that is ambiguous. Minor point, but it should be minor point, but if it was total plaque regression, the number is smaller than 15%. Not sure I fully agree on the PAV comment from Lily. A 1% annual PAV increase is the same absolute quantity of plaque relative to vessel size, regardless of how much plaque you started with. Would love to hear more from her on that. Also, just to be clear, as I've stated multiple times, Dave, while I don't agree with everything you've put forward, I do respect what you're doing. And he goes on to elaborate on the PAV point. I'll add to what I said in case it wasn't fully clear. The dominant determinants of coronary vessel volume, to my understanding, are body size, heart size, sex, and dominance, not plaque burden. Segments are included in the analysis by caliber, not by disease, so a clean tree still contributes its full vessel volume to the denominator. For two people of similar build, 1% PAV per year is close to the same annual cubic millimeters of plaque, whether they started at 3% or 20%. That's the point I was making. Where it gets interesting is what this means clinically. A 1% per year increment on top of 20% PAV plausibly carries more absolute risk than the same increment on top of 3%, because absolute event risk scales with total burden. And I think that's closer to what Lily was getting at. Yes, Simon, that's exactly what I was getting at. The 1% per year rapid progression threshold was determined in a population that was getting scanned for clinical reasons, meaning probably chest pain or shortness of breath with exercise. And so probably higher baseline plaque burden population, whether 1% at a lower baseline plaque burden or lower overall risk is the same clinically, we don't know, I would say. Or at least I am not as familiar with looking at that literature in a broader asymptomatic population, but maybe that's something we can take a deeper dive into going forward. Yeah, that said, if that rate were sustained for the 21 to 29% of keto CTA subjects or the rapid progressors adds up quickly, not progression I'd feel comfortable with as a middle-aged person with a lot of life ahead. Yeah, I totally agree with you. So thanks for the engagement. Glad to see you on the channel.
Headline: Lilly roasts Feldman and Norwitz. Is lean mass hyperresponder a disease? With approximately 40% of the U.S. population on a keto diet, which cause blood BHB levels of over 0.5 millimoles, the frequency is likely to be less than 1%. For what it's worth, I'll just say that I don't think, like true keto, I don't think there's more than 1% of the U.S. population on keto at those levels. So I already agree with that. So the keto CTA single-arm cohort trial was tiny at only 100 lean mass hyperresponders and very short, only 1 year. The lack of probity in continuing to reanalyze the data till it provides the right answer shines through. Feldman calls the limit of detection of the CTA scan the floor problem, but clearly on the graphs he showed the blue line that over half of the data points are with the confidence interval and are neither regressions or progressions. 3 of those classified as regressions are stable. Feldman then says this is quantum physics. No, this is random variation, and if the keto CTA trial had to repeat measures done within a month, say, we would get a better idea of the performance of CTA test in this trial. To draw extraordinary claims requires extraordinary evidence. This is from Sagan. Yeah, I thank you for the comment. Obviously, there's a lot of things to unpack there. For what it's worth, when I'm talking about the quantum physics, I was talking about superposition with regard to something being very unknowable. And that was where I was discussing with regard to the noise floor. So the closer you get to the smallest amount of change, the less confident you can be as to whether or not it's, a progressor or a regressor, which feels as if that's something you're kind of leading towards. And for what it's worth, I likewise would love to have test retests. It's just the catch is, unlike what Lilly's normally performing with CIMTs, which can be done as frequently as you want to, CT angiograms do take contrast dye. They do also take radiation. So even though they've gotten very low in the risk for both of those, it's still very relevant. That said, I'd really like there to be a lot more test retests with CT angiograms, especially with the newer technology, so that we can have that greater amount of accuracy.
At Captain Steve 777, tried to watch to learn more about both sides' positions, but not worth the pain. I'm on the Philovadia side. Dr. Lilly, you seem nice, but are too stuck in the traditional harmful paradigm and have a lot to learn. Echoes of the past when doctors said smoking was healthful, to statins are a miracle drug, to pile on the mRNA boosters. I'll be hoping for you to have a revelation in the future. Thanks, Captain Steve. I also hope for me to have a revelation in the future, and I have a lot to learn. I will freely admit that that is true, and I hope that I never stop learning. But thank you for your comments and for your feedback, and I appreciate the positive wishes.
Dave is such a charlatan. In less guarded moments, he says now that we know there's no relationship between ApoB and plaque progression. He is interested in looking at the real root causes of cardiovascular disease in metabolically healthy people. His theory is that it is binge eating. I do want to interject this real quick. That's a theory that I think is not widely explored enough, and it's just binging in general. It's not even necessarily binge eating. I think there's binging exercising and so forth, but I don't think that actually covers all of the etiologies of atherosclerosis. You have friends from out of town and eat unhealthy and flood the system with more than it can handle, causing vascular damage. I think that's a possibility. Dave's cohort excluded people that met every criteria who had high levels of plaque. So, of course, the people they enrolled did not have high levels. If they did, they were excluded. That's actually factually false. We definitely have people in our cohort that got recruited that had plaque at baseline, and you can see that within the study. Not only that, there are a number of folks like, say, Susan Bruni, who was one of the speakers at the Collaborative Science Conference, who was battling obesity for, I want to say, something like 2 decades. And that was another thing that I wanted to bring forward was, while our cohort was metabolically healthy, given the eligibility criteria, some of them had previously not so great metabolic health, but that can be relevant with regard to the outcome of this study.
At ApoB. ApoB doesn't measure cholesterol. It measures the atherogenic apolipoprotein B found in VLDL, LDL, IDL, and Lp(a). People really need to educate themselves on the topics they wish to debate about. Username checks out. Thank you, ApoB.
Agree that pussyfooting around is getting on my nerves. Dave Feldman needs to just let them have it. He's too nice. That's very kind, but for what it's worth, I actually thought the conversation was very productive.
At 4x4 Tahoe, I'd rather doctors learn to think for themselves rather than just follow the protocols and doctrines they were taught in med school, being open to the ideas that aren't currently mainstream. A patient shouldn't have to choose between listening to their doctor or their favorite YouTube influencer. Thank you, 4x4, for that. I completely agree. And there's a funny situation. The first day of medical school, we get these short white coats, and it's a ceremony called the white coat ceremony where we take our Hippocratic oath and everybody welcomes you as a medical student into the profession of medicine. And it's like very exciting and solemn and like full of gravitas. And there is always a speech during this ceremony that says, half of what you learn in medical school is wrong, but we don't know which half. Ha 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 ha. We all laugh. And then the next day, everybody forgets that that is the lesson, right? That's what we were told, because the next day we are full of certainty and 100% of what we teach you is right. And you will remember it and repeat it back to me. And that is the rest of your education, more or less. It's an oversimplification, but you get the gist. And it's one of my gripes with the current medical system is that most of us were sort of trained out of our curiosity and our intellectual humility. And, we didn't start that way, but it became kind of the culture. And I really hope that that changes. If that's something you're interested in learning more or hearing more about, there's a nice chapter in my upcoming book, Disconnected, that talks all about this. And you can find a pre-order link in the comments below or in the description below.
Dave and Dr. Lilly, do you agree with Professor Bart Kay and Dr. Vinny Prasad when they opine that the great majority of American allopathic physicians are clueless, incompetent to interpret and analyze scientific data? I can't say that I know that much, or for that matter, have watched a lot of analyses by allopathic physicians, so I can't really comment on it that much.
At Alan Madeira, Metz 1380, I think a 1-year study is too short to prove anything or make any claims at all. 1 year is pretty short in the grand scheme of atherosclerosis or plaque in the arteries, of course, and a lot of the big regression trials that have been done, especially with the lipid-lowering drugs, have been on the order of 12 to 24 months. So 12 to 18 months is not unheard of in the clinical trial space for heart attack, stroke, and plaque. For that reason, I don't think it's crazy to have 1-year data. That said, especially with the AI overlay, with low plaque burden at baseline, measurement error, and the wobble, it is tough to make a sweeping conclusion with 1 year of data. And it's certainly difficult to overturn a hypothesis that has a lot of multifaceted data points that come in from all directions to sort of, show us that at a population level, ApoB is associated with, and in fact, likely causal for the formation of plaque in the arteries. So I agree, 1 year is not as good as 2, it is not as good as 5, but A, I think there will be follow-up studies from the keto CTA cohort, and B, there are other studies in the field that are actually that short and do show some changes.
Dave, I'm trying to understand what hypothesis you believe keto CTA finding actually support. Do you hypothesize that chronically elevated ApoB is not causally atherogenic in lean mass hyperresponders? More concretely, if you could randomize otherwise comparable lean mass hyperresponders with ApoB around 180 to 200 milligrams per deciliter to either maintain that level or pharmacologically lower ApoB to 70 to 80 milligrams per deciliter for decades, would you predict no meaningful difference in plaque progression or ASCVD events between the groups? If you would expect the low ApoB group to have less atherosclerosis, then how should we interpret the finding that ApoB did not predict plaque progression in keto-CTA, given that study only compared people already selected for very high ApoB and had no normal low ApoB lean mass hyperresponder comparator? A few different things to unpack. One, one thing I've been trying to sort of battle is that a lot of people have assumed that we only had high levels of LDL and ApoB in our cohort, period, as though it's this narrow band, as though it's, a standard deviation of, say, 10 milligrams per deciliter. And that's just not the case. The LDL cholesterol I know offhand is 84.7 milligrams per deciliter standard deviation, which is to say the spread is gigantic. It's at like 450 to 500 LDL across our cohort. So we had a number of people that were even below eligibility. I want to say 17 of our cohort, because while the blood test that they sent us to qualify did need to be at least 190 or higher, as happens with LDL, it goes up and down to some degree. There were a number of people that were below 190 that anchored one side of the spectrum. And that includes some folks that were, I want to say, in the 130s and so forth. But on the other end of the spectrum, we had a number of people that were above 400. I think we had 8 total that were above 400 LDL. So we had enough of a gradient to actually take a fairly decent peak if there was a fairly strong association between LDL and ApoB and corresponding plaque presentation or progression. And I think that's very meaningful. But that said, I openly concede that there's still a good enough reason to get the longer term scans to see if there's even a modest association that might appear. And that gets to your question, which is when you're saying if you were to divide between these two groups and then maintain it for decades, we're probably not going to run this study for decades, but we would have a decade if we end up doing the 6-year scans as we're looking at doing. And that would be starting at the beginning of next year. And that would provide some very powerful data to help better answer that question. Moreover, the companion study we're looking at may actually do almost exactly what you're describing here. One of the things that's being discussed is we may pharmacologically add something like ezetimibe, which is a cholesterol absorption inhibitor. And if so, then half the group, the control group, the control group would be those who are left without the intervention. But it could be the intervention group actually has the lowering, and then you can actually see the effect size difference with regard to the longitudinal scans.
At Jacob Chobry, 3701, I was scared for that black cat with Dave Feldman in the room. I am personally unaware of Dave Feldman's relationship with cats, black or otherwise, but I will personally attest that 0 cats were harmed in the filming of this debate.
It would have been interesting to know if in the keto-CTA study, HDL functionality was better. It's not just a matter of whether HDL is high or low. Was PON1 higher, for instance? It's a very good question. I couldn't answer that right now. Biggest BSer on the web meets his match. The Nature CT was 2 years. I'm going to have to actually double check that one, but I believe Nature CT had on average 4.9. Clearly played politics and threw you under the bus. That should be known. No comment.
And at Sean Johansson 2022, my doctor came by to drop off the 4 different statins he prescribed me. Great guy. His Lamborghini is pretty cool too. So I guess I just haven't prescribed enough yet to get the Lambo. When Lambo? Until next time, guys, take really good care.